Hello, and welcome to today's webinar, Community Collaboration and Data Sharing Save Lives. Just a quick housekeeping note before we get started. Your phone lines will be muted throughout the entire presentation. We do invite you to submit questions at any time during the presentation using the question area on the webinar panel. Or, if you prefer, you can submit questions or comments through Twitter using hashtag #EcoviaWebinar. Today, we are talking about the Innovative Safe Station program in Nashua, New Hampshire. This program brings together local government, the fire department, and health and human service providers to help individuals struggling with substance use disorder. Our presenter today is Samantha Cassista, Quality Improvement Specialist at Partnership for Successful Living in Nashua. Samantha is a biological anthropologist who has worked in public health and the public sphere since 2009. She attended the University of Toronto and during her senior year was offered an internship and subsequently a position at the Mexican Institute of Social Security, a governmental entity that provides medical services and social supports to over 50 million Mexican citizens. There she was a junior analyst for the General Director's Office of Planning and Monitoring for a 50-point strategic plan that includes topics ranging from the Millennium Development Goals, including maternal and infant health, to infrastructure development for medical and non-medical facilities. The political role for nearly 3 years afforded Samantha a great foundation for nonprofit work, and upon returning to the United States, she immediately became involved with Harbor Homes and the Partnership for Successful Living in a development and strategy planning role. For all 6 partnership agencies, Samantha integrated their programs in the client track system in order to provide care quality and coordination, as well as to assist the administrative leads to view the entire partnership from a unified and common system. Her role with the partnership now includes building upon this integration and ensuring greater utilization of services for appropriate clients in a quality assurance role. Thank you so much for joining us today, Samantha. With that, I will go ahead and turn the time over to you.
Thank you so much, Laurel. I'm so excited to be here and to share information about our program that we feel very proud of. So the agenda for today, we'll first discuss the Partnership for Successful Living, a very innovative program or series of programs in New Hampshire, and the opioid crisis that we are facing in the state, and our response to it being the Safe Station program, how it came to be, some of our results. I'll take you into the client track world that I co-opted, something I had already made into being useful for Safe Station. And then because it's a very young program, which I'll be explaining in just a minute, we have some new and exciting ideas on the horizon that'll be coming forward in 2017 from all that we've learned so far. So with that, let me talk to you about the Partnership for Successful Living. So we're 6 nonprofits that attempt to work together in a coordinated manner, in a manner that's attempting to have a red carpet treatment where there's a no wrong door policy. And we all do various things, and we all specialize in different things. So Harbor Homes offers housing and a federally qualified health center. Healthy at Home does in-home care for people who have mobility concerns. And they specialize in mental health for folks with mental health issues as well as physical limitations. Keystone Hall is our largest substance use program. That's what they specialize in. They offer both inpatient and outpatient programs as well as a bevy of other innovative offerings that don't fit neatly into those molds. Milford Regional is one-on-one counseling, and they do family and couple counseling. They specialize in substance use and HIV, which leads me to the HIV/AIDS Task Force of Southern New Hampshire, a case management organization that's one of our absolutely most successful programs, where They offer people with low income some services for HIV, especially for their medical care, but also for just housing and for food and things of that nature. And finally, the Training Institute ties it all together with community events, education, and employment opportunities for the community, for peers in the community, for clients, and all of the above. So as I just mentioned, these are some of the realms in which the Partnership for Successful Living works together to try and offer a complete package of services to an individual as they come in. And ClientTrack has been extremely useful in making us a better product altogether because we are more integrated in this integrated database system than we ever have been in the past. And we've been together since 2007. So 2016 was a big year for putting us even more into each other's worlds and spaces. The topic of substance use is something that hits every single one of our 6 nonprofits 100%. So we are very well versed in the topic from many different vantage points, and it's not new news to us that New Hampshire has been having a crisis. We are, unfortunately, one of the things that New Hampshire is known for right now is having such a terrible state of opiate abuse across the whole United States. In 2015, there were 439 drug deaths and 397 were caused by opioids. We administered almost 3,000 naloxone or Narcan administrations to recover people from an overdose, and there were over 2,000 opiate-related emergency department visits, which are extremely costly. In Nashua, there were 19 fatalities in 2015 due to opiate overdoses and 37 in 2016. So Nashua has a very high number of services per capita, various nonprofit and even medical services per capita for the state of New Hampshire. We're pretty well off here. But even still, we saw a big jump from 2015 with 19 deaths to 37 in 2016. So we were looking at just a worsening situation. The community felt the effects collectively of losing people and nearly losing people every day. We were all in a state of crisis, and none so much as the first responders who would go to the same locations multiple days in a row and revive the same individuals multiple occasions. And in the end, they would be verbally attacked, physically attacked by these individuals who are coming out of a high, which is a self-induced state, into a Narcan-induced state that made them very despondent, confused, disoriented, and they reacted very badly. It led to a low morale for our first responders, especially since they didn't have an idea of how they could change the situation. They were just responsive. So one conversation that our state has taken on that I think the whole country has had the opportunity to take on, but New Hampshire has certainly done so, is the 1115 medical waiver. DSRIP, however you say it, is a Delivery System Reform Incentive Payment Program. And that doesn't mean a whole lot to everyone, but what it essentially does is it's a value-based payment wherein we collectively benefit by treating and paying providers who work on the social determinants of health that are driving up our care costs. And it's a method of cost sharing to improve outcomes for the Medicaid population specifically. And again, the partnership is very well versed in Medicaid, so this was right up our alley, and we have been able to become a part of it for the Nashua community. This is from the Opioid Public Health Crisis Update on the state of New Hampshire in August 2016, and it perfectly segues into the Safe Station program, so I'm going to read that for us. Reducing substance use disorders and related problems is critical to the physical and mental health, safety, and overall quality of life of New Hampshire residents, as well as the state's economy. The response to the ongoing crisis is only possible due to those working tirelessly in the substance use disorder and mental health provider communities, police departments, fire departments, emergency medical services, and due to the active, tireless, and selfless support of engaged citizens throughout the state. And that is essentially the cri de corps that created the Safe Station program, which I'll go into now. In 2016, with the election of our mayor, Mayor Jim Donches, the community of Nashua decided that we had to make a change, and he was the one who spearheaded it for us. He brought together initially in October of 2016 the fire stations, the police department, the ambulance, and the Harbor Homes and Keystone Hall as two of the primary entities from the Partnership for Successful Living to communicate on creating a solution that is a replica of the Safe Station program that had already been enacted in Manchester, our largest city in the state. The general idea is that anyone seeking treatment can find their way to one of the 6 fire stations in the city of Nashua, where firefighters will then have a text message system that will immediately get to the AMR, the American Medical Response, which is our ambulance company in this area, as well as Harbor Home employees. They will, if medically cleared, they will go to a Harbor Homes program, or if not medically cleared, they'll be brought to an emergency room. 15% of the individuals who came were brought to emergency room, and 85% were brought to a supportive service program operated by the partnership. So we are very proud of the fact that we have an 11-minute response time from when we are texted to when we show up at the fire station in question. We operate this at a 24/7 capacity, and we have vehicles specifically in place for this, as well as individuals who are peer advocates in sobriety, so that they have a friendly face that knows the system that comes to pick them up and transport them. The 11 minutes is very relevant because there's a study that says there's a general consensus and plenty of research that say that 15 minutes are all you have from when an addict says that they want to get treatment to when you can start responding and working with them. You only have a 15-minute window before a lot of them, a good proportion of them, will say, I've had enough of waiting. So we're very proud of our 11 minutes. We've been able to maintain that since November when we started. So at the Safe Station, the Harbor Home staff, when the individual is medically cleared, will then transport them to either the Harbor Homes Maple Street Emergency Shelter or Keystone Hall Outpatient. And it varies only due to the business hours. So during business hours, Monday to Friday, 9 to 4, an individual will go to the fire station, they'll be medically cleared, and they'll go to Keystone Hall Outpatient for a LADAC assessment and an evaluation and a discussion of what their goals are, what their resources are, what their barriers are. Taking all that into consideration, we make a case plan and we start making referrals to various programs. And based on availability, immediate availability of getting the person in, they will do one or multiple of the initial line of programs. So Harbor Homes Partial Hospitalization Program, Keystone Hall 28-Day Program, Harbor Homes Medication Assisted Treatment with Vivitrol or Suboxone, Keystone Hall Intensive Outpatient or Outpatient Program, Harbor Homes Gilmore Medical Respite, which is a detox center additionally, and an external treatment program has absolutely been used as well. So if a person already has a history with one of the other sobriety locations in our state and we can make that happen faster, then we'll definitely use that. Once a person, especially if they're in a partnership agency, one of these programs that I mentioned that's in color, once they're in any of these things, they are then allowed to, they're kept in the system and they're able to access any of the second line. So these programs are not necessarily first-tier sobriety programs, but they augment the services necessary to keep a person in a stable living situation, to keep them employed, to get them employed, to connect them to their family, to create social groups for them that they can lean on when they're in sobriety, and things of that nature. So running down the list, SAMHSA, our Harbor Home SAMHSA program, focuses on housing. It's only for those who are homeless, and they offer employment, case management of any sort, and counseling. Keystone Hall Open Door program is very interesting, and it's primarily for anyone who is addicted to something or in recovery, that they offer them housing, employment, case management, and that. The federally qualified health center operated by Harbor Homes includes medical, behavioral, dental, benefit coordination, and insurance navigation, as well as the Gilmore Medical Respite, which many of the people end up using. The peer-to-peer recovery centers are fantastic for people who are not necessarily in the Nashua region normally, that they're only in there for this time and this need. 45% of the people who have come through Safe Station are non-Nashua residents. So they benefit tremendously from a peer-to-peer recovery center, which is spread across the entire state. And they're operated by Harbor Homes to eventually be self-sufficient, sustainable recovery options in those areas. The Harbor Homes Veteran First program just celebrated a major success of achieving functional zero for veteran homelessness in the city of Nashua. And that program encompasses HVRP, which is about employment for veterans, SSVF, which is about family and veterans for housing and financial assistance. And then we also have GPD, or Grant Per Diem Transitional Housing Program. So with those things, we're able to really support any veterans who come through the system, which has happened, absolutely. Milford Regional and Southern New Hampshire HIV/AIDS Task Force have their own specialties, which I already mentioned, and so those can be great options, in particular if someone is located in their diverse catchment areas, Milford, New Hampshire, and Southern New Hampshire also has a location in Keene, New Hampshire. With all that, non-business hours option is not that different. There's just a couple key differences, so this slide will take a bit less time and you have a chance to look at it again. But essentially, the person will be brought to Harbor Homes Maple Arms Emergency Shelter instead, where a phone assessment and LADAC evaluation will be undertaken. That will then create a case plan that's a bit more of an immediate nature to make sure that the client is safe and comfortable and already beginning their process to recovery while being enrolled in what is ostensibly a housing program. So we have had a lot of cross-training to train up our housing people on being able to offer substance use services of sorts. If a person has medical requirements that would be more complex than our emergency shelter can handle, they'll be brought to Harbor Homes Gilmore Medical Respite, where they have 24-hour medical supervision. If their needs are not as acute and they simply need to wait in a safe, clean environment so that they can then become enrolled in a program during business hours, then they'll stay at the Maple Arms Emergency Safe Station Unit, which is outside of HUD territory, and it ends up being a wet shelter. It's the only location we ever operate that has that. And then finally, the next business day, the person will meet up with the Keystone Hall counselor, who will go through exactly what I mentioned in the previous slide, creating any combination of the first tier programs to get them into treatment and get them the treatment that's right for them, and then also hooking them up with any additional supportive services that can be useful. So all of this is our manner of doing care coordination. It's extremely active. We end up having some people who are co-enrolled in multiple programs at once because that is what they can handle, their recovery can handle, and that's how we like to do it. So a bit about the LADAC assessment and all that it encompasses. It's a licensed alcohol and drug counselor assessment. It's a comprehensive assessment. When done with a full evaluation, it can take at least an hour to get a full scope of the person and what their limitations are and barriers, in so much as, do they have any diseases that are specifically needed to be addressed? Are they already on methadone? And if so, what options does that negate? Do they have insurance or not? Are they housed or not? Things of that nature. So we've already alluded to what the key programs are, but medical respite is one of our best programs because it offers people the opportunity to detox under medical supervision, and that's very important for our clients. They require, a lot of the people that we have seen have not gone to treatment before because they are scared of detox. They don't like the first few hours and they don't want to go through it. So medical respite really helps to overcome those concerns. Other than that, we also have our comprehensive Keystone Hall residential and outpatient center. So those are some of our bigger ones. We also do a lot with partial hospitalization. So the data sharing in the partnership, in January of 2016, we launched our client track system that integrated all of the 6 nonprofits together. How we do that is incredibly HIPAA-minded, as we have to be. While we have many business associate agreements, memorandums of understanding, many documents saying that we can and should share information, we have to do the minimal sharing. We have to be conscious of what we share. So when we go into our system, you'll see that we have a variety of organizations. In the client track terminology, we have a variety of work groups and organizations. And the organizations are how we keep the data safe and secure, unless one individual will be sharing it across agencies, and then we use the referral system to open up information to the person who's receiving it, the provider who's receiving it on the other end. All of the 6 nonprofit data gets rolled up and sent up to our admin level, which is only seen by the data team here at the Partnership for Successful Living, which is very small. It includes only 4 people, myself included, and our president and CEO, who is the shared president and CEO across the 6 agencies. So this is an opportunity for him to finally see the entire world that we encompass. And that's something that had eluded him for 35 years of being our CEO and president. Some initial findings of the Safe Station program are, we only started it in November 2016. So how it started is our mayor told us we had to make it happen in October, and so we had no chance to create a budget, to hire new staff, or to create new things in Client Track. We had to go with what we had, and so I was able to co-opt something that we had, and it'll make more sense when we see it visually. But as I said, it started November 2016, really technically November 19th, I think, 2016, so right at the end. And since then, over 270 individuals have found their way into a safe station, a fire station. 225 of those people have been brought to a partnership agency, and the other individuals found their way to an emergency shelter. We have already, in just one point, we know that we have already saved our community $1.9 million, and it seems like an exorbitant number. But the way we know that is that the cost of staying in our Gilmore Medical Respite is merely $360 per night, whereas the cost of staying in an emergency room is at just the bare minimum is $2,500 for our community on average. So if you take that by all the people that have stayed in our program, and subtract the difference, it comes to $1.9 million. So that number floored me when I first saw it, but that's the case. 97% of our participants have been evaluated by a LADAC, which is the very first point of contact with sobriety, with the road to sobriety. So we're very proud of that. Only a few people just didn't make it to the point of getting the phone call and having it happen. 80% have gone on to receive at least one service from the Partnership for Successful Living. And one of the many things that we do is our federally qualified health center, which means that they get a physical, possibly for the first time in a long time. And of the people who had that, about 130 or so individuals have had a physical with us at this point. 56 of those individuals were found to be positive for Hep C. So what that means is, to me, what I see in that data is that these people probably had a higher propensity towards seeking medical treatment. And if those people, more than half of those people, are positive for Hep C, it worries me that the other individuals who didn't go for medical treatment possibly have an even higher percentage. The monthly patient counts have increased every month, which is something that's very exciting again to myself. Is I feel that this means that the community is learning about us and valuing the services that we render. So we have had similar programs where we try and become a referral entity. We try and help people. They can get into our one-stop shopping network, and those have not been as successful as this has been by far, because this one, we are not only we're offering people referrals, we're immediately going to them and bringing them to our locations. So that's really exciting. We've been able to capture insurance information for most people. Sometimes we don't get the information, which is 21 no info. But we were able to capture a lot of it. As you see, Medicaid is a huge part of the population that we're seeing through this program. And additionally, through our patient navigators in our federally qualified health center, the 38 that were recorded as having no insurance, we have been able to get 37 of those individuals onto a form of Medicaid for our state. The one individual who wasn't able to get on was making too much money to get Medicaid in our state. So we're really proud of that, to be able to offer them access to more programs by giving them funding that's not just out of pocket. This slide records the next level of care, which is what we try and we view when you come to the fire station. What is the next thing that happens for you? So as you can see, residential and Keystone Hall outpatient, intensive outpatient, are two of our biggest sources, with the third being that external community referral and treatment center. We've also been able to, as a result of this program, increase our medication-assisted treatment and our partial hospitalization program in line with the demand that has shown itself. And so we're starting to see those become bigger and bigger parts of the ways we treat people immediately. And there are, as I mentioned, the chance to do multiple programs at once. So this number will not ever come close to the 227 individuals that this will be far surpass that number. But these are an example of some of the ways in which our programs are being utilized. So you can take a look at that at your leisure. But as it highlights, the LADAC eval is one of our biggest ways of interacting with people immediately. Gilmore Medical Respite and our Safe Station unit are our next biggest ways. And then it goes down from there. So now I'm going to switch gears and bring us into the client track demo. So what you're seeing here is our training world to prevent any information from being shared. All of these names most of them are coworkers, to be completely honest, or completely made up names. Long ago, I created a crisis line log for a new program that we have, a program that we started in March of last year. That is the New Hampshire Crisis Line. And so, like I said, because we didn't have the opportunity to create anything special for this, I was able to co-opt this program using the work group and the organization structure built within Client Track. So this work group is the key thing that holds my crisis line log that I created. For the people who use the crisis line log, that is a program that it's not necessarily a enrollment program, it's only a referral program, one of the ones I alluded to before. So they use this organization, and their data is not shared up into the admin level because they're not technically a part of our organizations. And alternatively, those places that are our organizations are able to use this program, this crisis line log, for their own data, and collectively is shared at the admin level. So it really helps our administrators see the whole picture, which is very important. So the crisis line log is, well, you know what I like to do is I like to show the end result and then show how we got to it. So I'll do that first. This is my fake person based on an actress, but this is representative of a real individual who only received treatment as a result of the Safe Station program, and she had never had treatment before coming to our organizations and going through Safe Station, even though she had, in this case, it was an alcohol addiction. So it started, her real date of coming into Safe Station was 12/07. And this is exactly the number of programs that she went through and the programs that she's still involved with. Because she was homeless at the time, she's able to be in SAMHSA for ongoing housing support. That she also does with Open Doors, which has a stronger focus on finding housing providers who will work with a person in recovery. Our outpatient program and our relapse prevention program are two programs that train her and the skills she'll need to avoid falling into old habits. We're able to record case notes for her. I only did one example. We're able to record services for her, and this will only show the Keystone Hall services because that's the organization I'm in right now. If I were to flip into the HHI, the Harbor Home Clinical one, I would see the services for that. And then, or actually, because I've done them, I see both, but that's not very common. The assessments that are available to us in this work group is a bit limited in comparison to what's available to us in our full group, because these are the things that we have to do. We have to make a priority of what we're going to be asking them about. We don't want to overwhelm them with too many questions. So we're going to ask them on topics ranging right in these categories to help us craft a good case plan. And so that is our service plan. I'll just show you. If I switch to all, I'll show you one that's closed, and this is based on real life stuff that we had to detox her and get her into a 28-day program, that we had steps involved for that. And then after that, we had to maintain her sobriety, and that's what is an open case plan for this actual individual. We're also able to upload any documents to the system, including her ambulance record, which is very useful. A lot of the data that we have, especially the data at the entire Nashua level, is collected through the ambulance records, and then we in the partnership augment it with more specific data. So that's where we would keep it safe and sound. And anything else, any other assessments that we might do, including a Keystone Hall one. So this is Shelley, and I want to show you how it looks. So what this indicates to me is that she had a time being entered by both Scott Slattery from Harbor Homes and Rachel Doucette of Keystone Hall. So we know that the data will be different because it's coming from different individuals. And this is the most important stuff to collect. We have to know who she is, where she came from, and very importantly is a phone number, which was not recorded here but was recorded in the client record. So that's safe. We also then have to record what happened with her. And so it's a safe station call. We know who picked her up and from what fire station, information that we also have available to us from AMR records. So it's already reportable. And then we have what happened to her immediately and at what time it happened. And then finally, after we work with her at Harbor Homes, we'll get her eventually to Keystone Hall, who will be doing much the same. And one very exciting component of this is that this client could already exist in our shared database, or the client could be added for the first time. So I'll walk you through actually making this happen as if I'm having a call right now. And thankfully I'm in my Keystone Hall world, so it works out for me, because it would be during business hours. This is we consider it a call. So I'm going to look for my person first. She doesn't exist in the system, so I'm going to add her for the first time. It would have done a check for me at that point to see if the birthday corresponded with someone else in the system, but it has not. So I'll put in whatever I know. If that's the best knowledge that I have, then that's what I'll keep. Oftentimes, they will have a phone. And this is recording whether or not I'm able to leave them a message. If I'll have the person right in front of me, I'll be able to ask these questions. If not, I have the opportunity to say they don't identify any, that it was refused, or that it wasn't collected. And as you can see, I've made it so that there's very little that's required. Only the red asterisks are what's required. We want to collect all of this, and we're very successful in collecting it, but I didn't want to, especially if a person isn't completely cognizant and sober, to limit the ability to go through the workflow. So I knew that all this information is accurately in the system to the best of my knowledge. If she needs 911, then I'll contact it, record it, save it, and probably close the workflow at that point because it will be done for me. Or maybe I would go through with the best of my ability to put these things and put in a conclusion. That's not the case in this made-up example. So I'm just going to record these things to proceed. It'll then take me through to a barrier report, and I will identify my concerns for this individual. This is what this individual indicates is her primary addiction, the one that she feels is the most addictive. I'll say she'll need a medical detox. It'll connect with my provider world in Client Track and give me all of the options that are available to me. So I'll make a referral at this point for Keystone Hall. And then finally, I will record how this call went. So I'll say Fire Station 1, driver was Herv, one of our wonderful drivers. The call conclusion is that the client is on wait list for 28-day at Keystone Hall, pending detox. And then I'll press save, and I'll have completed my workflow, collecting the majority of the information that I need to proceed. If she is coherent, cognizant, I can then go into my client space and perform any assessments that I feel are relevant and necessary. The LADAC evaluation, which is external to this, will hit upon many of these topics, and therefore we will implement the data after the assessment happens. So I don't want to take much more time to show you this before I talk to you about some of the lessons we've learned and some of the things we're looking forward to as a result of this. The one last thing I want to show you is how, in particular for those people that we are not seeing in our partnership, this follow-up box is very useful to be able to say what's going on. I can think of one really wonderful example from the beginning of the Safe Station program where we had someone who went to an external program, and we were able to have contact with that individual every day for the first about 30 days of their program. They went from detox to a 28-day program. They kept in touch with us, and then they came back and became invested in one of our housing programs. So it was a wonderful example of how we work together and how we record it. So getting back to the presentation, one of the things that is fundamental to this conversation that was brand new for us is that our data team, which is really new, our data team used to be just me, and now we've grown to be 4 people. So that's great for me to have more support. But now, in this one instance, our data team gets to be pivotal and sitting at the table talking about real live people on a day-to-day basis amongst our providers, and that is truly transformatory for any person who has ever been in data. We usually end up having to be the watchdogs. We get to see things, but we don't get to comment. We get to make analysis after the fact, but we rarely get the chance to actually sit at the table and say, this person left, but we have this data on them. If they come back in, we can do this, that, or the other thing for their benefit, and it'll make a difference. And in doing that, we've come up with some little issues that we need to learn to get over. One of the issues is that our partnership can be a little too adamant about not allowing people to smoke. And that has lost us a few people who were on the path to recovery, but our concern about their smoking cigarettes really lessened their ability to stay with us. And in one case I can think of, it prevented them from wanting to come back until we were able to say, we've gotten a little bit more relaxed about that, and we don't want you to not work on your recovery because you need to smoke. That's okay. Another thing that we've determined that we always knew, but we have more quantifiable evidence for, is the need for more beds, more inpatient beds in our community, and their efficient use. So we have implemented using the housing module in Client Track for our own beds, and that is increasingly important to the point that we are going to start using all of, as my CEO calls it, the bells and whistles of the Client Track housing module, to include the wait list, to include facility incident reports, to include case logs, to record why people were turned away, to record why people weren't present. So we're maximizing the use of the beds that we have now to know any facility availabilities and utilization, and we're going to try and increase our beds, and I'll speak to that in a second. And finally, we've noticed that our program has less success, especially on Friday nights that lead into a long weekend. We have multiple people coming to stay in either of our locations, Gilmore Medical and Harbor Homes Emergency Shelter Safe Station Unit, that we have a harder time keeping them. So one of the things that we enacted is we're creating art therapy projects, and we're creating more projects that they can do to put themselves on the path to recovery even when they're not technically enrolled in a treatment program, because physically they're not capable of being enrolled until the next weekday. So looking forward, we have some really exciting things on the horizon. We're creating a budget. We've created a budget with the department, with a public health entity here in New Hampshire, in Nashua, I mean to say, to incentivize individuals to follow up with us after receiving services. And we're going to be discussing 5 measures that are still being debated on, like the specificity of them, but they'll revolve around client interactions with family, their physical well-being, their sobriety, their housing, and their medical care and their physical health. So those are probably the topics that we'll be looking for. We're also, as of this month, we created an enhanced employment service through Keystone Hall, one of the very new projects that they're doing, operated by a Harbor Homes staff person contracted out to us, to try and get the people who are on their way to recovery into employment options. And we are opening 55 new inpatient beds this year in 2017. In the building that I'm in right now, we moved and expanded so that we can have more space for people. Finally, we've increased the number of MAP providers, medication-assisted treatment providers, so we can see more people, reduce our waiting list, and we're looking into increasing the services that we're able to offer. Right now, we're able to offer Vivitrol, Suboxone, Subutex, and then eventually we're thinking about going into methadone as well, though we're still debating that. Finally, we're very, very excited about a mobile crisis unit that just is starting up for us and here at the partnership. And this program has been the key to us beginning this conversation for a mobile crisis unit. What it means is that an individual is able to contact us if they're in crisis from any location, and we will go and pick them up, obviously in New Hampshire. We'll go and pick them up, and we'll bring them to our facility and put them through the safe station process that we have been able to hammer out in these last 4.5 months. So, like I said, 4.5 months, not a lot of time, but we have learned by doing. And the 250 individuals who we've seen 277 times have been fundamental in making us improve ourselves as a partnership, improve our data, improve our care coordination, and we are just expanding as a result of it, and you just try and hold us back. That pretty much concludes my portion, and I wonder if there are any questions from anyone listening out there.
Thank you so much, Samantha. We are going to open up now for some questions. We actually already have a couple. If you have additional questions, please go ahead and submit them through the question area on the webinar panel. So the first question we had was from Jeff, and he said, how in-depth is the medical clearance performed by firefighters?
Well, Jeff, the medical clearance is performed in conjunction with firefighters and our ambulance response team. So the medical clearance is not extremely in-depth in my very non-clinical estimation. It is simply looking at blood pressure and at medications and at some physical traits of and with their knowledge and their ability to understand the human body in a way that's not as foreign to me, they're able to determine whether or not an individual ought to go to an emergency room. We have had some occasions where they have been medically cleared by the AMR and brought to our facilities, and this has particularly happened after hours. And in our after-hour facility, the staff there who are not medical professionals were finding that the person they were talking to, the client, was losing consciousness, and we had to call the ambulance, and they were brought to the emergency room at that point. And they have then exited, and our drivers will pick them up from the emergency room and bring them back through the process, back through the safe station process. So we have had some cases where we've had to, use our own judgment on what the state of the individual is. I hope that answers your question.
All right, thank you. We have another question from Jack. He said, what are you doing for smoking cessation, for getting people off of nicotine addiction?
Okay, so Jack, what we do is we offer them gums and patches to try and overcome it. We also try and encourage them through our classes to overcome the addictions. We have various services that are offered through Welcoming Light very routinely that are smoking cessation programs, including incentivized programs. But to be completely frank, we have found that this Safe Station program, as I said, 4.5 months, it is ill-advisable to try and get people to overcome their barriers for recovery, as well as their barriers for their other addictive qualities aren't illegal and aren't as, well, socially frowned upon, I suppose, and more dangerous. So we really do try and triage that the opiates and the alcohol, the things that are more likely to really harm the individual in the immediate day, have to be our priority. And so we have what we were doing that we have still maintained, but we've curtailed it somewhat, is we were demanding that people won't smoke in our facility. We still do that, but we weren't offering them smoke breaks. And we at Keystone Hall, our agency that knows this topic the best, came to Harbor Homes and to Gilmore Medical Respite and said, you guys have to offer them smoke breaks or you're going to lose them, because their addiction to their nicotine, in addition to their addiction for opiates, they're just going to say enough is enough and leave, which is what we were having happen. So we have been offering smoke breaks. We've also been using our partial hospitalization program, which is offered by Harbor Homes and in the same building, which includes smoke breaks, because it's a partial hospitalization. It's a 5-hour program, Monday to Friday, and it's 3 hours in the morning, an hour for lunch, and 2 hours in the afternoon. And so that is one way in which a Gilmore Medical Respite client who is on the tail end of detox can become involved with partial hospitalization. They can have their smoke breaks that they are desperately yearning for. And meanwhile, in the surrounding 5 hours, they're getting a heck of a lot of help with their sobriety. So, and then that ends up being one of the programs that they go into after their detox is complete.
Thank you. The next question is, how did you start the conversation with your community in order to do Safe Station? and what were some of the obstacles you encountered?
Okay. So the community was already somewhat knowledgeable about Safe Station from Manchester, having already done it before us. Our community welcomed it with open arms immediately, to be completely honest. Our community was yearning so much for an opportunity to get their loved ones or themselves into recovery. And, you know, in our state, one of the big problems, historical problems of our state, is that we have very few late acts available to us across the state. And we had, before the Affordable Care Act, before the Parity Act, that made substance use one of the 9 fundamental components of any health insurance, and that had to be treated equivalently to a physical health concern. Once that happened, that expanded our ability to treat people. It expanded our ability to get payment for treating people. It increased the number of late acts, and it increased the number of service providers. So now not only do we have late acts, but we also have many clinicians and many nurse practitioners that are becoming more involved and invested and knowledgeable and able to bill for these things. We also have peer recovery folks who are often just individuals who have some sobriety under their belt of their own, and then they go and it's a stepping stone for some people to becoming a LADAC. So it's creating a community a programmatic community in our state to increase our services, and hopefully it'll be one of the long-term ways we will combat our addiction problems in the state. So the community was already knowledgeable about Safe Station. I think that the merging of public entities which we trust and appreciate and value with service organizations like the Partnership, which has a good reputation in the community, and just partnering these two entities to say that we're going to work collectively to combat something that touches us all, it was just a breath of fresh air for all of us. So it was embraced immediately. I think also it's been continuously embraced because of the support that we receive from the public entities, the firefighters, the police, and our ambulance, because they believe in it so much and because they share their experiences and are so proud of their role in it. Our community is really buying into this idea, and it's showing because we're getting more people coming forward.
Well, we have another question that segues great from that about the community, and it is, how does the police department help with the Safe Station program?
The police department helps by offering support, and they do a smaller role, I'll be honest about that. The AMR and the firefighters have a more day-to-day role. However, our police force is very, very kind. We're not necessarily a sanctuary city, but we don't ask the questions about people's immigration status, and we aren't rushing to criminalize this. We have worked with our mayor and with the fire stations and with the Partnership to not criminalize when a person comes forward, so they don't have the fear that they're admitting that they're having a problem will lead to jail time. We have had some cases where, especially in the LADAC evaluation, you might be familiar that the LADAC asks questions that can be rather probing, and they're involving barriers, including any legal concerns that you have at this time. We need to know about those. So including sexual assaults and things of that nature, it can be pretty intense. So when a person is found to have a warrant out or something of that nature, they're being enrolled in Safe Station and the use of our community's use of a drug court has been really, really helpful in lessening the criminalization of addiction and in getting people not into jail but into treatment. And they utilize Safe Station on a daily basis. So we have a couple of drug courts in our community, one in Nashua. We also have a mental health court. And so we are intimately connected with those individuals who help our clients go from accepting their problem to overcoming it, and always take into consideration the impact their addiction has had on creating that problem and on prioritizing their recovery so that they won't become repeat offenders. So it's really through support that our police service is a part of this, but they were brought to the table so that they could be in alignment, in agreement with it from the start.
Thank you. We have another question from Suzanne, and she says, which organization hosts ClientTrack, or does each partner have their own instance of ClientTrack? And how are the costs managed for the database across the providers if it is shared? And how do you manage changes to the database across providers if it is shared? So let me sum that up again, since that's a long question. Does everyone have their own instance? How are the costs managed? And then how do you manage database changes?
Okay, yeah, no problem. That is right up my alley. So we have only one instance of it. It's owned by Harbor Homes, which is, as you saw when I logged in, it said ClientTrack /Harbor Homes _train. So Harbor Homes is the one that operates it, and we are very accustomed with this. So as the 6 nonprofits that work together, we share our president and CEO. We share his admin team, including his data team, the development team, our finances, our HR. We share things already. So we've already established well-honed policies for due to, due from scenario. With ClientTrack specifically, what we do is we have a concurrent user model, and so we monitor how the various agencies are utilizing ClientTrack and who is having to use it more, who's having to use it less. And we also take into consideration the employees within. So, for example, our HIV/AIDS task force is, I think, they might be a maximum of 10 or 11 not full-time equivalent employees who have an entry into ClientTrack. And we wouldn't want to penalize their proper use of the system because they're utilizing it fairly frequently. We wouldn't want to penalize it because we want them to put in that level of data. We want them to be using it very frequently. So what we look at is really about size of agency, the differing sizes of the agency. So just to paint the picture a little more clearly, Harbor Homes is by far our largest entity, and I think we're probably in the realm of high 270 to 80 employees or so, versus Milford Regional, which is 5 employees, Welcoming Light, which is 1 or 2, depending on full-time equivalents. And so, you know, we can't have Welcoming Light sharing a similar cost as Harbor Homes. Changes that occur, we had a ClientTrack implementation committee that represented every agency in our partnership who created everything that we did. And we came up with, before we even went live in January of 2016, we came up with what is our fundamental shareable use of information. What is our basic information? We came up with a standard intake, which has transformed the way we work, and it represents the partnership mentality better than any other way we ever had before ClientTrack. So, for example, Milford Regional, which does one-on-one counseling service, didn't necessarily take it a priority of asking about housing before ClientTrack came along, but we sat around the table and we said, you have to ask about housing. We need to know if these people are stably housed, because that impacts their health care, that impacts their mental well-being. And we need to know if they're having any addiction or a history of addiction that's relevant for you to know. You might find it out many moons later, but wouldn't it be preferable if you ask at the beginning? And so we worked together to create an intake that allows clinicians from Milford to hit upon all the different topics that could then allow them to make a better referral or to paint a better picture so that if that client ends up going to Keystone Hall, there's already some shared data they don't necessarily know how that client is in the system. In fact, they don't know. And some of the data that's more of a confidential nature, especially addiction and physical and mental health, is not shared at all. So they have to do their own questioning on that, and then that data becomes the property of that organization that's doing the questioning. So at the admin level, the Peter level, our CEO, he gets to see everything. So he gets to see the addiction from both the Keystone Hall perspective as well as Milford Regional. And it makes us all aware of what we do. It keeps us all connected to what we do. It's been transformative.
Well, thank you so much, Samantha. So we'd like to go ahead and thank you, Samantha, for the excellent presentation. And thank you to everyone for joining us for today's webinar. We are all out of time. So the recording and slides will be posted on our website tomorrow, and then we are also going to be emailing them out to attendees. We hope you will join us for future webinars. And also, Samantha has graciously offered to answer any additional questions we were not able to answer during our short time. So her contact info is on the screen now. It will also be available in the slides that we send out. Thank you so much to everyone, and have a wonderful day.